wherever you are. And if you are on the go or away from your TV, you can watch our free streaming service, CBSN 24/7 at our website, on your smart TV, or on your phone using the CBS News app. On the app, you can also sign up for our personalized alerts to keep you up to date on critical developments. Right now, we know you have a lot of questions and are looking for answers, and we want you to know CBS News is here to help you make sense of it all.
Special coverage of coronavirus Race to Respond on CBS This Morning, the CBS Evening News, and streaming on the CBS News app.
Here we go!
Here in Minnesota, we're proud of our accomplishments. We still believe in our communities, and we protect our quality of life. We're even stronger when things get tough. WCCO has always been here, capturing the images and telling the stories from all four corners of this great state. More Minnesotans watch WCCO than any other source. This is not a coincidence. WCCO, always.
Everything that happens in this universe has to be the way it is. Life's
WCCO.
We are breaking into programming for the Department of Health's daily COVID-19 briefing. Let's listen in.
Thursday Row. I would now like to hand the conference over to your speaker today, Mr. Mike Schomer. You may begin.
Thank you, and thank you to everyone for joining us for the COVID-19 daily media call for May 14th. Governor Walz is not on today's call. We will start with the situation report from Commissioner Malcolm. Following that, we'll hear an update from MDH Infectious Disease Director Chris Ersman. After that, we'll hear from State Epidemiologist Dr. Ruth Linfield, and then from Homeland Security and Emergency Management Director Joe Kelly. After those updates, we'll open it up for questions from reporters on the line. With that, I will now turn it over to Commissioner Malcolm.
Thank you, Mike. Good afternoon, everyone. We're starting with the data brief globally. As of early this morning, we were at more than 4.3 million cases and 297,000 deaths. In the United States, we were fast approaching 1.4 million cases, and we're at 84,100 deaths. Here in Minnesota, we announced an additional 520 cases over yesterday, bringing us to a new total of 13,435 cases. I will note that our doubling time, the number of days it takes to double total cases, is the same as it was last week at 10 days, despite testing a higher volume of patients. Sadly, we had 25 more deaths reported yesterday, bringing us to a new total of 663. 21 of these deaths occurred in residents of long-term care facilities. 14 in Hennepin County, 2 in Anoka, Stearns, and Ramsey, and 1 each in Brown, Clay, Dakota, Polk, and Washington counties. And that is the geographic breakdown of all of the deaths from yesterday. Demographically, this total includes 1 person over age 100, 6 people in their 90s, 7 in their 80s, 8 in their 70s, 2 in their 50s, and an additional person in their 30s believed to have had underlying health conditions. There are currently 498 patients currently hospitalized, an addition of 4 from yesterday, 203 of those in intensive care. I mentioned that we were pleased to see a new high total yesterday of over 6,700 tests processed by all the labs in the state reporting yesterday. That was our highest single day of testing. Just would like to remind people again, anyone who has symptoms of COVID-19 can and should be getting tested. We know that this guidance has expanded since early on in the epidemic. So we just want to reassure people that if you're feeling symptomatic, if you have some of those classic symptoms of COVID-19, respiratory illness symptoms, please do call your provider and see about getting a test. And of course, when people test positive and or if they feel sick, even without a test, please self-isolate. That means staying at home. That's a really key element of the Stay Safe Minnesota strategy that the governor announced and reinforced last night. We all need to do our part in order to protect our own health and that of our loved ones in our community. With that, I will turn it over to Chris Ersman.
Thank you, Commissioner. I just have 2 pieces of good news to share. As the commissioner indicated, we have had an increase in the number of individuals tested. And I'd just like to report that we reached our own internal milestone yesterday when we completed 650 case interviews in a single day. 500 of those were completed by MDH staff, so Department of Health staff, 150 by local public health. And we do want to acknowledge Stearns County, who took the record yesterday with doing 49 interviews. But just want to celebrate and acknowledge all the work that is going into making sure that we are reaching out to cases in a timely manner. And then the second piece of information that I wanted to share is that we are ramping up our testing in long-term care facilities as part of the governor's 5-point plan. We had a call with our our long-term care partners today to talk about this. And Director Kelly will be speaking more about the role that his area will be playing in assisting with this project. And with that, I will turn it over to Dr. Ruth Linfield, who's our state epidemiologist and medical director.
Thank you very much, Chris. I wanted to give a couple of updates today. My first update is that we are expecting a third shipment of remdesivir tomorrow. As you may recall, the federal government has begun sending out an allocation to states and territories, to the Veterans Administration system, as well as the Indian Health Service. And we do expect to receive a shipment tomorrow. This will be enough remdesivir to treat approximately 145 individuals for a 10-day course, and more individuals if they are on a 5-day course. And the determination about a 10-day versus a 5-day course has to do with the recommendations and the emergency use authorization from FDA, and in it, as well as our recommendations, that a 10-day course be considered for those individuals who are most severely ill, those who are receiving mechanical ventilation or extracorporeal membrane oxygenation. And for other individuals who are infected and have severe illness, we are advising clinicians to evaluate them at the 5-day point and determine if 5 days seem clinically indicated or if they should continue. We are planning our allotment to Minnesota facilities. We do this looking at the census in facilities of COVID positive patients who are hospitalized. And based on that, we come up with a proportion that goes out to the facilities based on the amount that we get. We have heard from the Assistant Secretary for Preparedness and Response that we are expected to get shipments on a weekly basis each week for the next 4 weeks. And they will determine the amount that comes to us based on the census of COVID positive patients in Minnesota hospitals. We do not know exactly how much we'll be getting on a particular week, and we do not know when it will be coming on a particular week. They usually let us know the day before it arrives. The next thing I wanted to mention is that you may have seen a new dashboard posted last night, and this has to do with the COVID-19 dial back measures. And the governor asked us to come up with some measures for which we can assess the outbreak in Minnesota, and he could use these in consideration of whether we need to dial back or not. We did come up with 4 indicators, and I'll go through them. But we are continuing to refine the measures, and over the coming weeks, we will potentially add some measures or tweak them as we see how it works and as we get more information. We base these measures on ongoing surveillance of testing and case trends in Minnesota, and we refer to federal guidelines and gating measures from other states. We do have a Minnesota COVID model that Stefan Gildemeister has talked about in the past, and a lot of great work being done with University of Minnesota. However, these measures are not derived from or tested against that model in case people have questions about it. When you look at that dashboard, you should be aware that there is a data lag period. And so to provide the most accurate information for laboratory testing, we are using a data lag period of 5 days to account for the time between the specimen collection, analysis, and reporting to MDH, because we want the data that we present on this dashboard to be as accurate as possible. For cases, we're using a 7-day lag period to account for case interviews to verify and collect the necessary information. If we don't have all the information we need for one of the metrics, it is looking at community spread. So if we don't have the data, we are not using those cases that have an undetermined source of exposure if we have not completed the interview with them. And we will be adding in additional data as we get them. So you may see some fluctuations, and I wanted to explain why that was. So here are our indicators. The first one is the proportion of tests that are positive. And so a positivity rate of 15% or more on average over 7 days, or a daily percent positive that increases 5 percentage points over 14 days is of concern. Currently, we are at a 14% average rate, and we have decreased 7 percentage points. We also have a measure to look at PCR testing capacity. And the current threshold, and this may change, is if PCR testing capacity drops below 5,000 daily tests on average over 7 days. And currently, as you have heard from Commissioner Malcolm, we certainly have exceeded that. We have had a 7,791 average daily supply capacity on hand. And this is, we assess this on a daily basis, but we take an average in order to smooth out some differences. Another measure is the case doubling time, and Commissioner Malcolm had shared those data as well. This is the days for a number of new confirmed cases to double, and whether it is on average a rate of 5 days or faster over a 14-day period. We are currently at an approximate 9.5 day case doubling time. And our last measure, and unfortunately this is the measure for which we have not met our goal, and that is community spread without known contact. And so this gives us a sense of whether there is more widespread transmission in our Minnesota communities. And the threshold for that is the percent of unknown contacts for a case is above 30% on average over 7 days, or if the rate climbs more than 5 points in 14 days. Currently, 36% of our cases have no known contact, and our rate has increased 16 percentage points. So of the measures I've described, this is the one that has not met our goal. The other measures that we are going to look at, I alluded to this, so just to give you a sense, we are also interested in looking at hospitalization rate and ICU rate. We are also interested in looking at cases among healthcare workers, personal protective equipment supplies on hand, trends in COVID-like illness, and the COVID-related death rate. It's taking us a little bit of time to develop the goals, but please look out as we do expect to have some additional measures on this dashboard so people can follow along with us the data that we are collecting and able to assess. Thank you. I will now introduce Joe Kelly, who is the Homeland Security and Emergency Management Director from the Department of Safety.
Well, thank you, Ruth, and good afternoon, Minnesota. As we ramp up the testing effort, including the special focus on long-term care facilities, Governor Walz activated some soldiers and airmen of the Minnesota Army and Air National Guard to support those operations. And this morning, 20 members of the Guard reported for duty to receive mission orientation. They got some training. They were issued some personal protective equipment and validated on the task of performing the collection of the COVID-19 test samples that we all now know as the nasal pharyngeal swab. Now, some people might get nervous at the thought of soldiers conducting these tests, but please rest assured, we didn't ask the Guard to send just any soldiers like infantrymen or tank mechanics for this mission. The military members that make up these teams are trained medics. In the Army, we refer to them as combat medics or healthcare specialists. The Air Force knows them as aerospace medical service specialists. In both cases, they complete about 4 months of skills training on patient care and treatment techniques, as well as emergency medical procedures. They are also required to earn certification as nationally registered basic emergency medical technicians, or EMTs. And on the civilian side, many of them work at clinical jobs, at hospitals, clinics, and other healthcare facilities. So the bottom line is, if you are being tested by a National Guard member, you can relax and be confident that you are in good and caring hands. The Minnesota National Guard is one of our most capable and trusted partners during disasters and emergencies. That force of 13,000 people, led by Minnesota's Adjutant General, Major General John Jensen, are skilled and experienced in a wide range of specialties. They have great first-line leaders and are self-supporting. And remember, Guard members are citizen soldiers and airmen. When we mobilize them for state service, we take them away from their civilian employees and their employers, and their families. And that's why we are always careful to make sure they are the last in and first out of operations. The Guard provides a surge capability and helps us bridge gaps. We often call on them to fill a breach when we need time to bring in other solutions. And these mobile COVID-19 testing teams are a perfect example of their value to our state. We will employ them during this testing surge and then release them when we can meet the demand with other options. Today, there are about 120 Minnesota National Guard members on duty, including these 20 testers for the coronavirus response. And again, please keep in mind that many of our Guard soldiers and airmen are also preparing for major training events and operational deployments overseas. We are asking an awful lot of them right now, as well as a lot of their families and their employers. Winston Churchill first coined the accolade "twice a citizen" as a measure of the value of Guard and Reserve members who serve our interests in both civilian and military capacities. So I hope we fully appreciate the dual service of these men and women and remain grateful for what they have done for our state and nation in the past, what they're doing currently, and what they've committed to do in the future. So with that, I'll turn things back to Mike for Q&A. Thank you.
Thank you, Director Kelly. We'll open it up for questions now. And as we do, we'll ask reporters to limit questions to one primary and one on-topic follow-up, and that you limit the number of questions from each outlet so we can get to as many as possible. With that, operator, we are ready to take questions.
As a reminder, to ask a question, you will need to press *1 on your telephone keypad. To withdraw your question, you can press the pound or hash key. Please stand by while we compile the Q&A roster. Again, that is *1. Our first question comes from the line of Jeremy Olsen from Star Tribune.
Hi, thanks. I just wanted to ask a kind of a status update question for our hospitals and our readiness. I mean, the purpose of the stay-at-home order was to give hospitals time to prepare, and healthcare providers and others. And now we've done that and it's ending. Does that mean that if the peak were to happen tomorrow, we're ready to go and respond? If not, what are our weak points and what still needs to be done?
Well, this is Commissioner Malcolm, Jeremy. Great question. I think we would probably want to get Marie Dotseth or Dr. Hick back on the call to address this in a little more specific detail. When we do look at those metrics and post them on the governor's webpage each day, that indicates how much ICU capacity we currently have, both what is just sort of the always available ICU capacity plus the 24-hour and 72-hour additional capacity that the health systems have planned for, as well as the current ventilator supply. And on both of those measures, we are still looking very much to be on plan. I know that as I think we've said in prior calls, we continue to work really hard on personal protective equipment. That is something that we will continue to try to bolster further our state supplies of that, just not only for the acute care system, but where we know there are additional needs for that equipment in long-term care and other settings. So don't for a minute mean to suggest that we're standing down or standing pat on preparations. All of that work continues, and the daily monitoring of capacity is really important. I think Dr. Hick has described before the standing up of a 24/7 resource line for providers to, if they are running into shortage situations in their local area, getting assistance with getting a patient to available capacity. So we can talk more about that in future days, if that would be helpful.
Yes, and then unless anyone else had comments on that, my follow-up would be, I was actually surprised there's no monitoring of the things that Dr. Linfield described of hospital capacity. And maybe you're watching that anyway, but I mean, if we're running out of ventilators, isn't that as important as like the testing capacity? Is there going to be a dial for that as well?
Oh, yeah, absolutely. That will be, and I think is already kind of a monitor on the global dashboard, if you will. But yes, that definitely is a measure for these sort of reverse dial metrics as we're referring to them. So yes, we will add that as well.
Thank you.
Next question comes from the line of Esme Murphy from WCCO TV.
Thank you so much, Commissioners, for taking my question. My question is this:
deaths are going up, hospitalizations are going up, cases are going up. We are working, dialing into reopening. How concerned are you, especially when you see the images from other states of crowded public gatherings? How concerned are you about reopening at a time when all of our cases are going up?
Well, Esme, that's a very, very fair question. And I think as the governor emphasized last night in his remarks, this is the whole intent here is for this to be a gradual and targeted and careful reopening that really is contingent on our businesses opening using best practices with social distance guidelines and engineering controls to keep workers and customers safe, and for all of us as citizens to be really adhering to that health guidance that you keep hearing over and over from us, that we don't go out if we're ill, and when we do go out, we're limiting our travel, staying close to home, wearing masks, being really vigilant about how we interact and with whom. And so I think the answer is we do need to keep close track of these metrics, and we will. The growth rates that we're seeing, we really keep emphasizing, kind of how measured are those growth rates, and are they within the capacity of the healthcare system to treat the growth that we see happening on a week-over-week basis. But there absolutely is a need for vigilance, both paying attention to the indicators, but all of us continuing to practice in the new normal. As the governor said last night, this is not going back to the way things were before the pandemic. This is attempting to move forward toward more economic activity and more very protected, if you will, social interactions. But we know that those are both very important things for the overall health of the state. So trying to strike that balance.
Just to follow up, the governor said that he would be ready at a moment if there was a spike in cases, or if there was an indication that there could be a spike in cases, to move dramatically to shut things down. What is the tipping point, or do you have a tipping point for that happening? And are you setting up different tipping points for different areas of the state? In other words, a shutdown perhaps could happen in one county or one city directed by you folks.
I think as Dr. Linfield went over kind of our preliminary measures for what would be those, you might refer to them as tipping points, or at least strong flashing warning lights that we need to look really closely at something. We have talked about and will continue to talk about whether some of those metrics or some of those dialing back strategies might make sense regionally. That is not where we are at present. We're taking a look at the entire state, but it is possible as we learn more about the status of the epidemic in different regions that we might do something of a more targeted nature. But the case doubling time, the testing positivity rate, the degree of community spread, and then those hospital metrics that we just talked about as well, all are the indicators we're going to be looking at.
Thank you.
Next question comes from the line of Emily Hovick from Care 11.
Hey, Commissioner and everybody. Thank you for taking my question. Could you speak a little more to the restrictions around groups of under 10? And I mean, just really practical tips for people who maybe as the restrictions start to lift, they want to become a bit more social, but they want to do it in a safe way. What does a safe gathering look like? Does it matter if you see the same people every week, or your group changes a lot week to week? Can you just speak really practically? And then, I mean, is it better to be in your backyard than in your home? I think we've talked about these things, but right now with the new order in place, what are you asking people?
Well, I'd certainly invite Chris and Ruth both to chime in as well. And I think our guidance up to this point has been really to restrict gatherings to household members only. And so this additional flexibility allows for gatherings of less than 10 people, not restricted to the same household, but still to practice social distancing, to be at least 6 feet apart, ideally to wear masks. Certainly being outside presents a little bit more of a safe zone, if you will, as opposed to confined indoor spaces, but that social distancing, masking, obviously not gathering if anyone in the group is ill. All of those things are just perhaps more important now that we be vigilant on that with the intent of allowing some additional social interactions. So Chris or Ruth, would either of you like to comment further?
This is Ruth. The only thing I would add, and I'm sorry, Chris, I'll turn it to you, is that we still are really concerned about our elderly and people with underlying conditions. And we really do want them to be safe. And with this virus, it really is a stealth virus because people can transmit it before they develop symptoms, and some people don't develop symptoms or they develop very subtle symptoms. And so we really want to protect these individuals, and we really encourage them to stay home as much as possible. You know, if you have an elderly neighbor, I think the governor talked about this, maybe do their grocery shopping for them and drop it off. Don't have a face-to-face prolonged conversation with an elderly neighbor. You know, really take this seriously. We want people to take this seriously. As all of you have articulated, this virus has not gone away, and it really is up to all of us to do our part to keep transmission down and to really continue to work with those measures. Chris.
The only thing I was going to add was just to simply say that even as you're considering your social distancing and being outdoors, remember that your exit and entrance matters. So in other words, if everyone's coming together to then get to the point where they're 6 feet apart, you want to avoid that. So just make sure that you're considering your exit and entrance as you're considering your distancing.
Can you clarify that a little bit? You mean people all walking in through the same area? Or are you talking about going on car rides with others?
Well, I guess both. Obviously, if you're driving with someone who's not in your household, then it's difficult to social distance. But I was thinking more of, you know, you're bringing 10 people together and you figured out how you can all be 6 feet apart for the event. You want to make sure that you're using this, having the same attention to detail for social distancing when everyone arrives and when everyone leaves as you do during the time when you're interacting. Because oftentimes you can have people clumping together, if you will, as they're coming or going. So just that's an important part of the whole process.
And another good reason to wear masks when you're in the car or in close proximity, especially.
Thank you all.
Next question comes from the line of Matt Sapit from Minnesota Public.
Hi there. I guess this question would be for Joe Kelly. How is the mobile team testing going in these long-term care facilities, and what do you think that the pilot program might be expanded? You said there were 20 people doing the actual testing. What are the other 100 National Guard members doing in terms of supporting those? I know that's a bunch of questions there. Yeah, thanks, Matt. I'm going to answer the last one first and then probably turn the long-term care testing, mobile testing back to the epidemiologists. The other 100 or so National Guard personnel that are working, in addition to supporting this testing mission, they're working in our operations center, helping with planning. Of course, they're still working on, a couple of them are still working on the alternate care site, and there's a fair number of them working in providing support to our personal protective equipment or PPE warehouse. As far as the time horizon for the long-term care testing, I'd be more comfortable pushing that back to the Department of Health.
Jen, do you want to take that, or do you want me to?
Why don't you, Chris?
So we are working with both the State Emergency Operations Center, as Director Kelly said, as well as working with facilities to talk about the importance of testing. As I mentioned, we just had a WebEx with them today to go over what the plan is, what considerations they need to think about as they're ramping up to do testing in their facilities. So our expectation is that this testing will go on over the next number of weeks, and the National Guard is assisting us to help get that jump started. We're looking to have some strike teams that will be stood up that can assist with testing if facilities don't have a health system or usual provider that can help them. And so all of those things are being put in place, but the testing is starting now and it will continue, and we expect that it will be ongoing for a number of weeks moving forward.
Okay, and just to clarify, Chris, has a Guard medic actually taken a test or given or I should say taken a COVID-19 sample from someone? Have they been at the facilities? Are they doing what has been planned?
My understanding is that it is now 2:36, and I believe they were going to be starting some of that at 1. So my assumption is that yes, they have done that.
Okay, and then just a quick follow-up. Are they testing facilities that have had confirmed cases or people with symptoms? Or are they going to all facilities regardless of prior confirmed cases?
We are starting with facilities that have had a confirmed case, and they are testing all staff and all residents of those facilities. And once we've gone through the facilities that have had a case, we wanted to start there, then certainly, yes, we will be testing even more broadly.
Okay, and then, sorry, just one, are there plans to expand it beyond these 20 medics? Or are you going to need more Guard medics to be helping out with this? And that's seriously my final question.
Well, as I mentioned, we are in the process, and when I say we, this is Director Kelly, the State Emergency Operations Center, the department, all the partners that are working together to make this happen, are working on standing up some strike teams that would be available to do testing in regions. So our desire is that if a long-term care facility has a relationship with a health system, that they would use that health system to do testing for them. If they already work with a certain provider, that they could go ahead and do the testing that way. If we have a situation in which a facility doesn't have that as an option, then we have the ability to pull in a strike team that could help with that. So our goal is that facilities would be working with their usual provider of care, but in a situation where that's not possible, then there would be these strike teams. And the Guard is serving as a bridge between our current state and our desired state with the strike teams to help us get to that point and to make sure that we're testing even as we're in process.
Okay, thanks everybody.
Next question comes from the line of Tom Hauser from KSTP TV.
Hi, my question is for Chris Erzman. Chris, a couple of weeks ago, you told us that 99.24% of the deaths in Minnesota were people with significant underlying health conditions. Can you update us on that number, where that stands now? And have you considered making that part of your daily dashboard?
We are at, for the cases who have died, 98.8% have identified an underlying health condition. And so just to be clear, we always have an element of missing data because we are in the process of adding to our data each day, but we have 493 of our deaths that we have information for, and 493 that we know had an underlying health condition, 6 that we know did not have underlying health conditions, and then we are still waiting to get data on 164, but we're at 98.8.
And have you considered making that part of the daily dashboard?
Well, you know what? We will do that. We will consider that now. Thank you.
And Joe Kelly, quick question for you. Can you give us an update on the warehouse facility for the human remains and also the facility in Roseville that would help with overflow in case the hospital's still up with COVID-19 patients?
Yeah, thanks, Tom. We are in, I guess, I'm not a real estate agent, final negotiations and working through the paperwork for the acquisition of the building. So I do expect that warehouse to be purchased early next week, that we would be able to close that deal. The alternate care site in Roseville, they are probably, I would say, 2/3 to 3/4 of the way through the reconditioning and modifications to that building, and all of that work should be completed by the 22nd of May, which is, I believe, next Friday. So that's well on track.
Okay, thank you for the updates.
Next question comes from the line of Bill Werner from Minnesota.
Thank you, Commissioner and others. This follows off of something that Dr. Linfield said, but I think that Commissioner Malcolm, it may be for you. Talking about the 4 dial-back indicators, specifically the third or the final one, which Dr. Linfield said we're not meeting this one, the community spread. Given that, is there a possibility that the governor's target to allow reopening of restaurants and bars and gyms and hair salons and the like, that we may not be able to make that by June 1st?
Well, I think the governor laid that out as the goal and is directing state agencies to produce some detailed guidance that would enable those businesses to plan for safe reopening. But I think he was careful to say we'll keep our eye closely on the situation, and if we see significant degradation in these measures, that would be a real cause for concern, and I'm sure he would consider very carefully whether we could move ahead with that goal date. But he felt it was important to set some parameters for businesses to be able to start planning for that time that we all look forward to. But we'll have to do it obviously carefully and presuming that the situation is still stable by our best ability to judge it.
If the indicators, Commissioner, stay, I'm talking about not only the 4, but obviously the other things, hospital and so on too, the other key important indicators, if those stay relatively stable or in directions that you're saying are positive. In other words, from where they are now, if they stay kind of in that same range, would it, in your opinion, be prudent to reopen bars, restaurants, et cetera?
Well, there certainly will be continued conversation about that, but I think the announcement last night and the indication of the intent to keep moving forward toward a gradual reopening, again, just have to emphasize all conditioned on our collective ability to practice in a new normal with a lot more social distancing and a lot more adherence to personal health guidance. That conditioned on all of those things, I think our assessment is that as we've seen the epidemic unfold in Minnesota, our general rate of community spread has been pretty moderate. And I think Dr. Linfield pointed out that there's data lag and in some of the metrics. So we need to dig a little bit deeper into the community spread measure and the testing positivity measure. Those are both trying to get at kind of the same thing about how much spread there is in the community overall. So I anticipate also that we'll be doing some more surveillance testing in the near future to try to add some additional data to just the the test positivity rates that are coming in through the symptomatic testing. Sorry for that long answer, but I guess all of that is to say we have our eye sharply on these measures, but we're also looking to add to the measures and to maybe have some better disaggregation of some of the data underneath these averages.
Thank you, Commissioner.
Operator, we have time for one more question.
Okay, our question comes from the line of Greta Call from MinPost.
Hi there. Wondering, we got the modeling update yesterday, but still haven't heard if there's an updated answer on the percent of Minnesotans that we think have been infected with COVID-19. Any update on that since the model's out?
You know, I'm sorry, I don't have that in front of me. I think they did. I'm going to say, and Chris, maybe you remember, but I thought it was something in the order of a 5% case detection rate, but I could be wrong about that.
And then just as a quick follow, we heard reports that in Wisconsin, people are packing bars as the Supreme Court knocked down the order, the governor's order. Are you worried about anything like that happening in Minnesota once things start opening back up?
Well, you know, I think the governor could not have been more clear that if this is going to work, we're going to have to do this in a really careful and intentional way to keep social distancing and to keep those protections in place. And we all do have we can all contribute to doing this successfully or not. So I think we would certainly hope that that Minnesotans would continue to practice the kind of aware and considerate behaviors that we're all going to need to continue to do, and especially as my colleagues pointed out earlier, to be particularly mindful of those vulnerable folks in our communities that are going to need extra support because of the extended nature of this virus in our community.
Thank you.
That's all the time we have today. I want to thank our speakers and the reporters on the line. If you have questions we were not able to address during the call, please feel free to reach out to our office at 651-201-4989. Have a good day, and we will talk with you again soon.
That was today's COVID-19 briefing by state leaders. A few big takeaways there. 25 people in Minnesota